Good time. We are talking about vaginal tumor. Vagina is a muscular dilatable tube averaging 7.5 cm in length. It is composed of three layers: mucosa, longitudinal coat of muscles, adventitia. The covering epithelium, composed of non-keratinized squamous cells, normally contain no glands and changes little during reproductive cycle. It is continuous inferiorly with the epithelium of vestibule and superiorly extend to squamocolumnar junction. The muscle coat is attached superiorly to the fiber of the cervix and inferiorly and laterally to the pubococcygeus, bulbospongiosus, and perineum. Lymphatic drainage of upper vagina via the pelvic node, while the lower vagina drain via femoral and inguinal nodes. Vulval intraepithelial neoplasia is a squamous premalignant lesion classified as a type 1, 2, and 3. 1 to 6% seen in a patient of cervical intraepithelial neoplasia. It is almost always affect the upper vagina. Mean age 53 years old. The ratio of vein to CIN is 1 to 3, 1 to 23, which is mean rare. 5% progress to vaginal carcinoma. It is not common to find vein in the presence of a normal cervix. Pathological hallmark of vein: on microscopic examination, there will be cytological atypia, so that we see pleomorphism, irregular nuclear contour, chromatin clumping, and there will be abnormal maturation, nuclear enlargement. These are the picture. Here is a type 1. There will be proliferation of the basal layer, choleocytotic atypia, while this is a type 2. There will be proliferation of the basal layer, crowding, and loss of polarity, choleocytotic atypia. Here is a type 3. There will be increased proliferation of abnormal basal and parabasal cell, replacing full thickness of the epithelium. About etiology, due to oncogenic human papillomavirus 16, it may be caused by extension of the CIN onto the vaginal fornices and is often found after hysterectomy due to incompletely excised CIN. It may be found within the surgical margin of the vault also. A high incidence has been noted in a patient on chemotherapy or immunosuppressive therapy. Radiotherapy for cervical cancer patient has been blamed for the vein or vaginal sarcoma. On clinical evaluation, asymptomatic, most cases so detected on colposcopy, and during examination by colposcopy, we see aceto-white epithelium with punctation and mosaic pattern. The most investigation is biopsy, which must be full thickness to ensure invasion is not missed. Treatment: for localized area of the disease, we have laser vaporization for the type 1 to 2, and excision is preferable for the 3, especially if the previous hysterectomy done. White strip changes throughout the vagina. We have vaginectomy for it. It is done for recurrent or widespread disease, especially if there is possibility of early invasion on biopsies. In young women, strategy to do partial vaginectomy. And other treatment, we have imiquimod cream, which is increased immunity, and we have 5-fluorouracil cream, radiotherapy. 1 to 2% of gynecological malignancies, vaginal carcinoma. Approximately 3,000 cases are diagnosed annually in the United States, with almost 900 deaths. Primary tumor is rare. The majority are secondary from the cervical, endometrial, vulval, ovary, breast, rectum, and kidney. Vaginal metastasis may occur by direct extension, example cervix, vulva, endometrium, or by lymphatic or hematogenous spread, example breast, ovary, kidney. Wide age range, we have 18 to 95 years old, with the peak incidence in the 6th decade of life, and a mean of age approximately 60 to 65 years. There would appear to be no relation with the race of parity. Most of these tumors are squamous cell carcinoma, but we have also melanoma, sarcoma, adenocarcinoma, and other histological types also occur. The etiology of the vaginal carcinoma is unknown, but There may be due to human papillomavirus 16 and causes, which is this virus lead to vein, and as the result go to vaginal carcinoma. We have irradiation, more common in immunosuppressed, and also associated with the CIN, either because of the latter spread or incompletely excised hysterectomy. Previous gynecological malignancy seen in 1/4 to 1/3 of cases. Most presentation is vaginal bleeding, which accounts for 50% of cases, and sometimes present with a vaginal discharge, urinary symptoms, and abdominal mass or pain. Asymptomatic approximately seen in 10% of cases at the time of diagnosis. Important clinical notes: we have vaginal tumor may be overlooked during vaginal examination, particularly when a bivalve speculum used. So careful inspection of the vaginal wall while withdrawing the speculum is necessary to avoid obscuring tumors in either anterior or posterior wall of vagina. About pathophysiology, majority, which is 92%, is squamous cell carcinoma. We have malignant melanoma, are rare and carry a poor prognosis with early hematogenous spread. Other type, we have sarcoma, as for melanoma, and we have clear cell adenocarcinoma from vaginal adenosis due to uterodiethyl stilbestrol exposure. So this used in 1945 to 1970 to prevent miscarriage. 1 in 1,000 women whose mother took this develop a clear malignancy, typically between 15 to 22 years old. 10% occur without exposure to this drug. The pathophysiology, the upper third of the vagina is the site most frequently involved. 1/6 of cases involve full vagina. The size show great variation at presentation, ranging from the small ulcer less than 1 cm to 2 to 4 cm pelvic mass. Now we are coming to staging. We depend on FIGO classification. We have 4 stages. In 0, which is carcinoma in situ, while 1, which is invasive carcinoma but limited to the vaginal wall. We have 2, stage 2, we have A and B. A, carcinoma involve subvaginal tissue but does not extend to parametrium. And stage 2B, carcinoma involve parametrium but does not extend to pelvic side wall. Third stage, carcinoma extend to the pelvic side wall. In A, involvement of the mucosa of the bladder or rectum, so this is called bullous edema, does not qualify for stage 4 or direct extension beyond true pelvis. The B is spread to distant organ. These are the picture of the metastasis according to staging. Stage 2 is most commonly found at presentation. Stage 1 and 2 combined constitute 70 to 80% of cases. The spread is squamous cell tumor spread locally to the bladder or bowel, and lymphatic to the pelvic node in the upper 2/3 and inguinal node in the lower 1/3. Hematogenous spread is rare. Clinical evaluation: by history, we found vaginal bleeding, vaginal discharge, pelvic pain. On examination, urine examination, which is important, we do combined rectal and vaginal examination. On colposcopical examination with 5% acetoacid detects pre-existing vein and reveals extent of the lesion. Cervix must also be assessed to exclude coexisting lesion. Cystoscopy and sigmoidoscopy are required. Investigation, which is important: biopsy must be full thickness for formal histopathological staging. Depth of invasion into the mucus and muscle is significant in staging. MRI of the pelvis is important to assess local invasion and lymph node involvement, and CT scan of the abdomen and chest for melanoma and sarcoma. Management. The management, we have limited indication for surgery. If the patient presents with stage 1 but is in upper 1/3 posterior wall, while the patient with a small mobile stage 1 tumor in lower down in the vagina also done by surgery and bulky lesions that are unlikely to be cured by primary radiotherapy. In stage 1 to stage 3, chemoradiation including brachytherapy, so this is internal radiotherapy, the vaginal epithelium is thin and the bladder and the rectum are nearby. Thus, surgical margin of 1 cm can be achieved only by removing the bladder for anterior lesion and rectum for posterior. Chemoradiation we can use as a primary treatment is organ preserving. Regimes are similar to cervical cancer, but the radiations field are altered to concentrate radiation to exact tumor site. Stage 4, this patient needs palliative chemoradiation. Treatment is individualized according to tumor site and symptom. Radiotherapy is associated with significant morbidity and mortality. One of this is vaginal stenosis is found in third of the cases, ulceration of the vaginal mucosa, 10% there may be fistula. Radiation cystitis is common, with the burning sensation on urination, frequency, and incomplete voiding. Stress, incontinence, and urgency may also occur. Diarrhea affects 50% of patients receiving radiotherapy, may be permanent, occasionally causing fecal incontinence. About the recurrent disease, it occurs locally or within the pelvis in most cases, about 20% relapsing with distant metastasis. Majority of relapses occur soon after primary therapy, median of 8 to 9 months. Poor prospective and majority of the treatment is unsuccessful. Usual treatment choice will be anterior and posterior exenterative surgery if localized. Survival rate for vaginal carcinoma, stage 1 is 80%, stage 2 40%, stage 3 30%, stage 4A, which is 10%, stage 4B distant metastasis, this is less than this. So prognostic factor depend on the stage, site, and histological grade and type. Thank you for your listening.